Echogenic bowel, like many other aneuploidy markers, is nonspecific and can occur in normal fetuses. Approximately 0.5% of normal fetuses have this finding, making it uncommon. Normally, during the second trimester, the bowel is homogeneous and echogenic like the rest of the fetal abdomen, making it unnoticeable. Echogenic bowel might be seen as abnormally echogenic. The clinical significance varies according on the degree of echogenicity. To minimize subjectivity in clinical identification of echogenic bowel, some have implemented a grading system. Some will only recognize intestine that is significantly echogenic on sonography, whereas others will detect both moderately and markedly echogenic bowel. The recommended grading system for echogenic bowel is as follows. Grade 1 is mildly echogenic and often diffuse, Grade 2 is moderately echogenic and typically focused, and Grade 3 is extremely echogenic, comparable to bone structures, preferably the iliac bones. Echogenic bowel is more frequent in aneuploid fetuses, especially those with trisomy 21. In this sonogram, a Down syndrome fetus with echogenic bowel, referred to by arrows, in the fetal abdomen, and it is classified as Grade 3. As you may note, echogenicity is quite similar to that of the vertebral bodies of the fetal spine. Echogenic bowel may raise the risk of trisomy 21 by 6 to 7-fold. However, the risk varies according on maternal age, existence of other structural abnormalities, and other risk factors. The risk of Down syndrome in isolated echogenic bowel ranges from 1.4 to 2%. Echogenic bowel can be caused by congenital infections, for example, cytomegalovirus, herpes simplex virus, and parvovirus. It can also be due to cystic fibrosis-induced meconium ileus, or intestinal obstruction or atresia or malformations. Echogenic bowel should not be confused with meconium peritonitis, which is identified by peritoneal calcification on prenatal sonography. Please note that echogenic bowel differs from hyperechoic meconium found in the third trimester, which is often limited to the colon. Therefore, when an echogenic bowel is detected, it is important to conduct maternal studies for congenital infection, cystic fibrosis carrier status, invasive testing for fetal karyotype, and serial scans throughout the pregnancy to rule out intrauterine growth restriction and bowel malformations or atresias, which may not be visible until the third trimester.